मीडिया साउंड ऑफ कर दिया। मीडिया साउंड ऑफ है ना।
Good evening, respected teachers and my dear co-PGs. Today I'm going to start a seminar on WBC disorders. I'm sorry for the inconvenience caused, but now the problem is fixed and I'm going to start this seminar. My contents are introduction, white blood cells, leukopoiesis, the disorders of white blood cells. They are grouped under quantitative disorders and qualitative disorders, conclusion and references. Now, what is the introduction? First is blood. Blood is a unique bright colored when it is present in the artery, and dark colored venous when it is present in the vein, and it is of variable composition circulating throughout the vessels of the body. It participates in all the physiologic and pathologic activities in all the organs, and it is highly complex fluid which is composed of two parts, that is the liquid part is plasma and various different types of cells, that is RBC, WBC and platelets, which constitute about 45%, and they are known as the hematocytes. Now, the composition of blood, it consists of cells which are the blood cells, RBC, WBC, and platelets. It contains 91% to 92% of water, and solid, which contains all the metals, along with serum albumin, serum globulin, fibrinogen 7.5 percentage, as well as non-protein nitrogenous substances like urea, uric acid, carbohydrates, fats, etc. Various enzymes are also present like amylase, protease, lipase, and various pigments like bilirubin and carotene. Now, we are going to concentrate on the white blood cells. White blood cells are the colorless and nucleated formed elements of the blood that helps in the body's defense mechanism. They are first formed primarily in the bone marrow and partially in the lymph tissue that consists of the spleen, thymus. After it is formed, it is transported by the blood and lymphatic to various parts of the body. The white blood cells consist of mucoproteins, lipids, glycogen, cholesterol, ascorbic acid, and a variety of enzymes, especially proteolytic enzymes. These are some of the features of the white blood cells that distinguishes from the red blood cells. The white blood cell is colorless. Its number is 4,000, normal range is 4,000 to 11,000 per mm cube. Its size is 18 micron. Its shape is irregular. It has different shapes. Its nucleus is present, whereas in RBCs it is denucleated. It has various types. That includes the granulocytes and agranulocytes. It has a lifespan of a half of a day to 15 days. The types of RBC are broadly divided into granular or granulocytes and agranular or agranulocytes. The granular one, they include neutrophils, eosinophils, and basophils, and agranular or agranulocytes includes the lymphocytes and the monocytes. Now, this is the picture of the white blood cells. The monocyte and the lymphocytes are the agranulocytes, whereas the eosinophils, basophils, and the neutrophils are the granulocytes because it contains granules in them. The granules can be differentiated or stained with the help of a specific stain which is known as the Wright stain. The eosinophil, basophil, and neutrophils, they are either they have more than one lobes, but the monocytes and the lymphocytes, they have single lobes. The neutrophils is three-lobed and it contains neutral stains like eosinophil and basophil. The eosinophils contains only the eosinophilic stain, and the basophils contain the hematoxylin stains. Now, among this, the abundance is present. The abundance WBC that is present in our body is neutrophils, which consist of almost 50 to 70% of the total body. Now, these are a brief discussion about how much percentage it is present in our body and the absolute value per mm cube. Neutrophils 50 to 70% with a range of 3,000 to 6,000 mm cube. Eosinophils 2 to 4%, 150 to 450 mm cube, basophils 0 to 1%, 0 to 100 mm cube, monocytes 2% to 6%, 200 to 600 mm cube, lymphocytes 20% to 30%, and 1500 to 2700 mm cube. Among this, the neutrophils and the monocytes are basically concerned with the phagocytosis of various foreign body. Eosinophil is concerned with the any allergic or any bacterial infection. Basophils are concerned about, they are concerned for excreting, or they are concerned of secreting various heparin, histamine, and lymphocytes give rise to formation of B lymphocytes and T lymphocytes, which controls the immunity of our body. Now, this is the entire process of leukopoiesis. The blood stem cells, or the pluripotent stem cells, they give rise to the myeloid stem cells and the lymphoid stem cells. And from the myeloid stem cells, we get the myeloblast, which is again divided into granulocytes, and that is divided into various granulocytes that includes the eosinophils, basophils, and neutrophils. And on the other hand, the lymphoid stem cells, it is divided into lymphoblast, and the lymphoblast is further divided into B lymphocyte, T lymphocytes, and natural killer cells. Now, this again, T lymphocytes give rise to various the mast cells, macrophages. Mast cells give rise to macrophages. The macrophages that is present in our body is it is present in the liver as Kupffer cells, and the alveolar macrophage in the lungs. Now, the various functions of the WBC, it has a property of phagocytosis, that is, it engulfs the foreign bodies that enters into the tissue, and it engulfs and then digests it. It has a property of defensive mechanism. It secretes various lymphocytes that helps in various defensive mechanism. It also has secrets strophones, which help in the growth and the repair of the tissues. It also helps in heparin, which is a anticoagulant. It also helps in antihistaminic functions, as well as the formation of fibroblast, which is also act as a defensive property. These were all the functions of the WBC. Now, what are the pathological variations in different types of WBC? Neutrophilia, which is known as the increase in the neutrophil count, it happens when there is an acute infection, metabolic disorders, infection of the foreign proteins, and poisoning of various metals, or any injections or something like that. Neutropenia, it is a decrease in the level of neutrophil count, and it happens when there is bone marrow disorders, tuberculosis, typhoid, and various autoimmune diseases. Eosinophilia is termed when there is an increase in the amount of eosinophil, and it happens when there is allergic conditions, blood parasitism, scarlet fever, intestinal parasitism. Eosinopenia is a condition defined for decrease in the eosinophil count, and it happens in Cushing syndrome or hypercorticolism, bacterial infections, stress, prolonged administration of drugs like corticosteroids. Basophilia is a term for increase in the basophil count, and it happens when when we are prone to various viral infections like smallpox, chickenpox, polycythemia vera, increase in the number of RBC. Basopenia is a decrease in the basophil count, and conditions like urticaria, stress, prolonged exposure to chemotherapy and radiation therapy causes this condition. Monocytosis is the increase in monocyte count, and it happens when there is tuberculosis, syphilis, malaria, kala azar, etc. Monocytopenia is a decrease in the number of monocyte count, and it happens when there is a prolonged use of steroids. Lymphocytosis is an increase in lymphocyte count, and it happens when the person is susceptible, or the person is affected with diphtheria, infectious hepatitis, mumps, rickets, tuberculosis, malnutrition, thyrotoxicosis, syphilis. And the last, lymphocytopenia, is a decrease in the lymphocyte count, and it is seen in cases of AIDS, Hodgkin's disease, malnutrition, radiation therapy, steroid administration. Now, the main topic is disorders of WBC. Disorders of WBC are broadly classified into quantitative and qualitative. In quantitative, we can differentiate it further by the decrease and increase in the number of WBC, whereas in qualitative, it shows the quality, or the quality of WBC is affected. Now here is a classification of all the qualitative disorders. Decrease and increase in the numbers of all the leukocytes is described here. This is a classification. Agranulocytopenia, neutropenia, an increase in the number, granulocytosis, neutrophilia, basophilic leukocytosis, eosinophilic leukocytosis, lymphocytosis, and monocytosis. Now, this is a qualitative disorders classification. It includes the lazy leukocyte syndrome, Chediak-Higgesi syndrome, multiple myeloma, infectious mononucleosis, lymphoma, and leukemia, and everything is broadly described in the further slides. Now, first of all, agranulocytosis, which is also known as neutropenia or granulocytopenia. It is associated with the reduced number of leukocytes. When the absolute neutrophil count is less than 1000, the absolute neutrophil count has a range of 1500 to 8000 per microliter, but when it decreases to 1000, then there is an increased susceptibility of infection. When it further decreases to 500, then the control of endogenous microbial flora gets impaired, and when it further decreases to 200, then the local inflammatory processes is absent. Here, the normal range of absolute neutrophil count is almost 1500 to 800 per microliter of blood. Now, these are the various etiology of neutropenia. Infections. Infections include all infections that is either viral or bacterial or parasital or rickettsial, all the type of infection. Disease includes all the metabolites diseases, which includes the diabetes or acute gout or acute liver problems or glomerulonephritis. Hemodialysis is also contributes in neutropenia. Irradiation, excessive radiation therapy can also lead to neutropenia. Deficiency of various enzymes and various vitamins also causes neutropenia. Various drugs, antimetabolites, or various higher doses of chemotherapy or any some antibiotics can also lead to neutropenia. This is the clinical features of patients with neutropenia. Age and sex. Any age, and it is more common in adults, female predilection is more. The occupation is in health workers because they come in daily contact with the drugs, and they are more prone to neutropenia. Symptoms are gradual or sudden onset, sore throat, fever, malaise. Sign is there are necrotic ulcers on the mouth and the throat, and patient dies within 3 to 5 days. Oral manifestation, sites, commonly on the gingiva, palate, tonsil, and pharynx, and symptoms are pain, excessive salivation, spontaneous oral hemorrhage, appearances necrotizing ulceration on oral mucosa, tonsils, and pharynx. Surface of lesion ragged, necrotic, and covered with a grey lac membrane. Margins of the lesion shows lack of inflammation at the margins, and the supportive structures, they spread quickly through the supportive structures, and there is loss or loosening of the deciduous and the permanent tooth. Now the management is the removal of the causative agents. Blood transfusion should be done if the hemoglobin level is less than 10 gram per dl. Antibiotics along with corticosteroids therapy should be given. Now there are also granulocyte macrophage colony stimulating factors. They can be done, and splenectomy is advisable only when the stage is not high. Oral management, we can give any antibacterial mouth rinse, Cepacol or Listerine can be given. Soft splint can be given, which is with a medication that is useful, and it is useful in palatal ulcers, which completely covers the maxillary arch. Also, we can give analgesics, 5% diclonine with 5% diphenhydramine hydrochloride, which is mixed with the magnesium hydroxide with kaolin with pectin. This is the oral management we can do with the patients. Now, the various common variants of, there are so many variants of neutropenia, among which there are two most common variants according to Burkitt: chronic neutropenia and cyclic neutropenia. Cyclic neutropenia is also known as periodic neutropenia. It is a rare hematologic disorder characterized by the repeated episodes of fever, mouth ulcers, and infections attributable to recurrent severe neutropenia. It is an inherited autosomal dominant disorder due to the mutations in the gene for neutrophil elastase ELA2 located in the position 19p13.3, and it recurs after a regular interval of 21 days, and it persists for 3 to 5 days and characterized by the infectious agents. Now, what are the oral manifestations? The hallmark is periodic oscillation of neutrophil count associated with fever and mouth ulcers, and the common findings are recurrent aphthous stomatitis along with gingivitis and periodontitis, and most severe consequences of this type of neutropenia are gangrene, bacteremia, septic shock. Because of the ulcers, they sometimes perforate to the colons, and infections are caused. And the most important bacteria involved is the Clostridium septicum. Now, the management also has antibiotic therapy, gentamicin, penicillin. If contraindicated, then clindamycin. Corticosteroid therapy, prednisolone can be given. Cytokine granulocyte colony stimulating factor can be given, splenectomy can be done, and oral hygiene maintenance can be done. Chronic neutropenia, it is a congenital, acquired, or idiopathic and is defined as a low absolute neutrophil count for more than 6 months. It has two predominant types. One is chronic benign idiopathic neutropenia and severe congenital neutropenia, which is also known as Postman syndrome. The first one, chronic benign idiopathic neutropenia, is characterized by a prolonged non-cyclic neutropenia as the sole abnormality, there is no characteristics to be attributed as neutropenia. There is no cyclic neutropenia is seen there, and there are no characteristics of the disease seen here. But in severe congenital neutropenia that results from the mutation of various genes, for example, ELANE genes, ELANE, HA1, GFI1, all these genes are they mutate and cause this severe congenital neutropenia. But from the beginning, not all the genes are involved. Monogene is involved. Any one of the gene is involved, and it subsequently forms or it subsequently mutates the other genes. Now, the clinical and the bacterial oral manifestation is bacterial infections, recurrent gingivitis, severe periodontitis, often starting in early childhood because it is a congenital form. Periodontitis of primary dentition and early loss may be represent the sole manifestation of this disease. Chronic benign patients with severe congenital neutropenia experience deep tissue infection with lung abscess, liver abscess, and severe skin infections. Now, what is granulocytosis? It is abnormally large number of granulocytes in the blood and mostly commonly associated with an increase in neutrophils. Now, this term is known as neutrophilic leukocytosis, neutrophilia, and it has a total number of here the total number of WBC is more than 11,000, with an absolute neutrophil count more than 7,700 per microliter. Now, this is the normal range of the neutrophil, 1500 to 8000, and here we have 11,000 per micrometer. Now, the etiologies are infection, bacterial, mostly viral infection is it contributes to this. For example, Epstein-Barr virus, and the respiratory virus, respiratory syncytium virus, stress, smoking, pregnancy, myeloproliferative disorders, non-infection. In cases of non-infection, there is metabolic disease or systemic diseases, metabolic condition, poisoning of various metals, mercury. All these things contribute to the granulocytosis. Now, leukemia. Leukemia, it results from the proliferation of a clone of abnormal hematopoietic cells with impaired differentiation, regulation, and programmed cell death. Now, a clone is something that is a genetically similar body that happens, that is done or that is intentionally done in various serological departments or laboratories. It is the proliferation of a clone of an abnormal hematopoietic cells with impaired differentiation, regulation, and programmed cell death. It is defined by a rapid disease which progresses over weeks to months and ultimately culminating in bone marrow failure. It is also known as a cancer of the blood forming tissue. tissues, and it is basically divided or classified into two. It is based on two things, based on clinical behavior, acute and chronic, and the second is based on primary hematopoietic cell line affected, myeloid or lymphoid. Myeloid is something that arises from the bone marrow, and lymphoid is something that arises from the lymphatic tissue. So here we have four variants: acute myeloid, acute lymphoid, chronic myeloid, and chronic lymphoid. Now, these are the ulcerations seen on the lip, crust, crusted ulceration on the lips and palate in leukemic patients. Now, these are the four principal diagnostic criteria: acute myeloid leukemia, acute lymphocytic leukemia, chronic myeloid leukemia, chronic lymphocytic leukemia. Among which, the acute lymphocytic leukemia is most common in children. Now, this is a tabulation showing acute lymphocytic leukemia and acute myeloid leukemia. Now, the definition: acute lymphocytic leukemia, it is a clonal proliferation of lymphoid cells that have undergone maturational arrest in early differentiation, and it is more common in childhood, which have children younger than 5 years of age. It has a more oral manifestation of, it shows ulceration in the mouth, gingival enlargement, dry lips, mucosal pallor, mucosal pathology, ecchymosis, and ulcers. And the treatment given are chemotherapy, allogenic hematopoietic stem cell transplantation. Chemotherapy can also be combined with molecule kinase inhibitor. Induction therapy can be given. Induction therapy is the first line treatment that is done before any surgery or before any treatment. And also CNS prophylaxis should be done. CNS prophylaxis should be done to prevent any relapse of the disease. Orally, we can give methotrexate and daily mercaptopurine, dexamethasone, vincristine. Vincristine can be given 1.4 gram can be given on the first and the 14th day. Now, acute myeloid leukemia, it is defined on the basis of morphological, cytogenetic, and molecular criteria, and the subtype is acute promyelocytic leukemia. Its median age of onset is 66 years, but 70% of cases are seen in 55 years of age. And the major feature seen here in this condition is disseminated intravascular coagulation. So here we can do induction course of cytotoxic therapy as well as stem cell therapy. For patients with acute promyelocytic leukemia, we can also, there is a different type of treatment given, that is transretinoic acid with anthracycline based chemotherapy to reverse the coagulopathy that happens because of the intravascular coagulation. We can give this therapy of ATRA, that is all trans-retinoic acid and anthracycline based chemotherapy. Now, chronic myelogenous leukemia and chronic lymphocytic leukemia. Chronic myelogenous leukemia, it is a clonal disorder resulting in myeloid marrow hyperplasia and myeloid cells. Here, there is mutation or translocation takes place in the chromosome number T, in the Philadelphia chromosome of number T922, and it is mostly seen in adults and rare in children. It has a common manifestation of fever, weakness, fatigue, anorexia, weight loss, splenomegaly, anemia, and infection. The diagnostic confirmation can be done by when the Philadelphia chromosome is responsible here. It decreases the fusion, or it doesn't allow the fusion of the BCR and ABL fusion genes, and thus there is a translocation in the T9 and T22 chromosome of the number of this Philadelphia chromosome, and then we can confirm this leukemia. The treatment is imitinib, omacetaxin, mepasucinide, stem cells transplant, nilotinib plus dasatinib. Chronic lymphocytic leukemia. It results from the slow accumulation of the clonal B lymphocytes in 95 patients. It has two types. The first one is slow and the survival rate is almost 15 years, and the second type is fast and the survival rate is almost 8 years. It is seen in a median age of almost 65 years. Here the common manifestations are fever, night sweat, weight loss, fatigue, lymphadenopathy, anemia, thrombocytopenia. And the lab test which should be done for this is finding out protein like ZAP70 and 3D38. Here, if the levels of 3D38 and ZAP70 is decreased in the patients of chronic lymphocytic leukemia, the patient shows proper prognosis or gives good prognosis. Also, we can check for the lymphocytes which are greater than 5,000 for a month. If it is seen for some months, and if the lymphocytes are greater than 5,000, then we can conclude that this is a chronic lymphocytic leukemia. Also, if the medications given are purine analogs, monoclonal antibodies, rituximab, and the gold standard treatment is FCR, that is fludarabine, cyclophosphamide, and rituximab. Now, lymphomas. Lymphomas, they are the solid tumors of the immune system, and they are of two types. One is Hodgkin's and one is non-Hodgkin's. Hodgkin's lymphoma constitutes 10% of the total lymphoma, and non-Hodgkin's lymphoma is constitute 90%, and it is also known as lymphosarcoma. Now, the Hodgkin's lymphoma. It is a neoplastic proliferation of the lymphopoietic portion of the reticuloendothelial system. The reticuloendothelial system is a system that is present in the cells, and it regulates all the types of all the filters and every types of cells and all the functionings, and it regulates all the cells. It has a bimodal age distribution, means it is first seen in the peak of third decade, and secondly in the peak of almost 55 years, and it is more common in males. According to WHO, it has been given a classification of lymphoid neoplasm. We can distinguish between two major subtypes of Hodgkin's lymphoma. The first subtype is classic lymphocytic predominant and nodular lymphocytic predominant, and the second subtype is nodular sclerosis, which constitute about 60% to 80%, mixed cellularity 15% to 30%, lymphocyte depletion less than 1%, and lymphocyte rich, which is almost 5%. These are the two major subtypes of Hodgkin's lymphoma. 95% of the patients have a classic Hodgkin's lymphoma histology, which shows the presence of a rare malignant Hodgkin's Reed-Sternberg cell pathologically. The staging system that is used is the Caldwell system, which has a modification, which was a modification of the older Ann Arbor system. Here, according to the staging, stage 1 shows involvement of lymph node in any one structure, the involvement of only one lymph node region or lymphoid structure. Stage 2 shows involvement of two or more lymph nodes regions on the same side of the diaphragm. Stage 3 shows involvement of lymph node regions on both sides of the diaphragm. And stage 4 shows involvement of the extranodal sites other than one contiguous or proximal extranodal site. Clinical and oral manifestation. Asymptomatic enlargement of the supradiaphragmatic lymph node is seen here, and clinical manifestation shows chest pain, cough, dyspnea, night sweat, fever, weight loss. Infection in the oral cavity, ulcer or swelling in the oral cavity mostly presents as a hard cavity, and physical examination reveals involvement of the Waldeyer ring structures. Waldeyer ring is a lymphoid structure that is present. It comes on the lymphatic tissue, and the physical examination reveals the involvement in the lymph nodes in the Waldeyer ring. The management is radiotherapy given 3,500 to 4,000 rads per week in stage 1 and 2. For stages 3 and 4, the first combination of chemotherapy, that is miclorethambin 6 milligram per m square IV on day 1 and day 8, oncovin, which is also known as vincristin 1.4 mg IV on day 1 and day 8, procarbazine 100 gram orally from day 1 to day 14. Prednisolone is given 40 milligram per millimeter square orally from day 1 to 14. Second combination is adriamycin 25 milligram given IV bolus on day 1, 8 and 14, bleomycin 10 milligram IV bolus on day 1 and 14, vinblastine 6 milligram IV bolus on day 1 and 14, dicarbazine 375 milligram IV bolus on day 1 and 14, and chemotherapy. A combination therapy of chemotherapy and radiotherapy can be done. Splenectomy is advised, not on the advanced stages. Now, non-Hodgkin's lymphoma, which is also known as lymphosarcoma, it is a neoplastic proliferation of lymphoid cells, usually affecting the B lymphocytes. It has two histological variants, nodular and diffuse, and it is commonest in the middle age groups. Males are more common here. The symptoms that are seen are fever, weight loss, fatigue, sweating, abdominal pain, nausea, and vomiting. Oral manifestations seen are oral manifestation, swellings on the palate, oral cavity, buccal mucosa, and palatal lesions also appear slow growing, painless, bluish soft tissue masses, as well as paresthesia of the mental nerve may be reported. Sometimes there is the pain in the fifth cranial nerve, second and third division also is seen in this. Management, chemotherapy, chlorambucil plus prednisolone can be given. Radiotherapy, 150 rads for a period of 5 weeks is done, and stem cells transportation, hemopoietic cells, allogenic hemopoietic stem cells transplantation can be done. Now, Burkitt's lymphoma, it is also known as African jaw lymphoma. It was described by Dennis Burkitt in 1950, and it is a lymphoreticular cell malignancy that involves the B cell. It is highly aggressive and it is the fastest growing lymphoma. It is non-cleaved cell lymphoma and it has three variants. One is endemic, sporadic, and immunodeficiency related. uh, according to WHO, but there is also one variant which shows the endemic and the non-endemic variant. Endemic is the African variant, and the non-endemic is the American variant that is shown in some books. Now, the oral manifestation are a rapidly growing tumor mass of the jaw that destroying the bone with the extension of that involves the maxillary, ethmoid, sphenoid sinuses as well as the orbit. Loosening or mobility of the permanent tooth is seen. Gingiva and mucosa become swollen, ulcerated, and necrotic, and swelling causes facial asymmetry, and it is capable of blocking nasal passages, displacing the orbital contents, and eroding through the skin. Now, the tumor spreads periosteum that invade the oral cavity and face, where the rapid tumor growth obliterates the face and skin becomes tense and shiny. Also, asymmetry, facial asymmetry is seen here. Cytotoxic drugs like cyclophosphamide 40 milligram per kg in single IV and is given, and we have to repeat it after 2 weeks. Vincristine and methotrexate and multi-agent chemotherapy can be given. Multiple myeloma, which is also known as myelomatosis. It is a malignant neoplasm of the plasma cell of the bone marrow with widespread involvement of the skeletal system, which includes the skull and jaws. It is characterized by a clonal proliferation of malignant plasma cells in the bone marrow microenvironment, monoclonal protein in the blood and urine, and associated organ dysfunction. It is multicentric in origin. Here, the oral manifestations are the mandible is more commonly involved with pain and swelling, and numbness is experienced. Intraoral swelling is ulcerated, rounded, and bluish red. Pallor of the oral tissue, intraoral hemorrhage, susceptibility to infection is seen. Oral amyloidosis. Amyloidosis is a protein. Amyloid is a protein, abnormal protein that is seen, and oral amyloidosis is a complication of this lymphoma. Here, what happens? The amyloid proteins are deposited in the tongue as well as in the gingiva or in the palate everywhere. So what happens when it is deposited in the tongue? That the tongue swells and there is inability to deglute or inability to talk. And also when there is the amyloid deposition starts in the gingiva, patient suffers inability to wear the dentures. So this is a complication of this lymphoma. Also, oral hairy leukoplakia and candidiasis is seen because of the incomplete or improper oral hygiene. The management is chemotherapeutic agents they are given. Management of anemia and hypercalcemia is done. Blood transfusion if the hemoglobin is less than 10 gram. Stem cell transplantation of allogenic siblings or matching siblings can be done. Radiotherapy can be given and biphosphonate therapy can also be given. Now, these are two syndromes which are associated with the qualitative disorders of the leukoplegia. This is the lazy leukocyte syndrome or the Swatchman syndrome. It results as a loss of chemotactic function of the neutrophil. As we all know that neutrophils are the first line of defense and they are attracted towards the damaged tissue with the because of the chemotactic actions. So the loss of chemotactic function of the neutrophil causes this lazy leukocyte syndrome as the name suggests. It is apparent in 1 to 2 years of age and oral manifestations seen is stomatitis, periodontitis and other manifestation are otitis media in the ear, bronchitis, and it has an absolute neutrophil count of 100 to 200 cells per mm cube, and the management can be antibiotic therapy. Another syndrome here is the Chediak-Higashi syndrome. It is a congenital autosomal recessive defect of the granulocytes and melanocytes. Abnormal granules are seen on the granulocytes, resulting in decreased bactericidal and chemotactic activity. The granules they contains various defensins and catechins type of enzymes which helps in the bactericidal and chemotactic activities. Therefore, abnormal granules they causes the decreased bactericidal and chemotactic activity. The oral manifestations are ulceration, periodontitis, gingivitis, and glossitis, and the management can be antibiotics, prednisolone, ascorbic acid, allogenic bone marrow transplantation, debridement and drainage of the deep abscess. These are my references. Mouth is conclusion is mouth is a mirror of health. There are a lot of systematic disease where the clinical and the oral findings are seen prior to any investigation. Therefore, it is necessary for a dental professional to take proper clinical examination in order to achieve a proper diagnosis. Thank you. And the fastest growing tumor is Burkitt lymphoma because it has a capacity of growing very fast and it has a capacity of growing very fast. So this is the fastest growing tumor. Most common leukemia in children is the acute lymphocytic leukemia. It is most common in children. Uh, the prognosis uh, is not good, sir. It has a bad, poor prognosis.
Done.